Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, fresh off a trip to New Orleans from ASPS, here today with my amazing co-host, Dr. Millicent Rovelo, who has a massive premiere coming up very soon.
Very, very soon. I have a premiere coming up in 2 weeks on TLC, October 29th, in case we haven't mentioned it already. But I also
We did a
have
whole
another
podcast
trip
about it.
coming up next week, too, to Oslo, by the way. I have my own trip
Oh, that's
coming
right.
up. So that's the first thing that's coming up. But that's not what we're talking about today.
No, today
We're talking about your trip today.
We'll talk about what went on at Plastic Surgery, the meeting, which is the American Society of Plastic Surgeons meeting that was in New Orleans. And I'm back with some kind of cool, takes on some things. It was good, really interesting. The meeting quality, I think, has gotten a lot better over the last few years. I'm happy to report. And I sat in a lot of rhinoplasty sessions, a lot of facelift sessions, and a lot of breast sessions because, I don't get to breast meetings, but I get to facelift meetings and rhinoplasty meetings pretty frequently.
Yes.
It was good.
It was good. Yeah. So typically we go to the aesthetic meeting or the Aesthetic Society of Plastic Surgery meeting, and this is more geared towards aesthetic surgery. So the cosmetic aspects of what we do, facelifts, breast augmentation, tummy tucks.
That's not till the spring.
That's not till the spring. And there's a whole nother society that we both belong to, that most plastic surgeons belong to, and that's the American Society of Plastic Surgeons. And this is sort of the general umbrella of plastic surgery. It encompasses the stuff we do, some of the aesthetic stuff, but also the more reconstructive things as well. So it's where you get some of the more academic presentations. And so it's a nice umbrella of all things related to plastic surgery. Historically, it was not always very strong when it came to aesthetics because we had the Aesthetic Society, which is a whole different society, a whole different meeting. And so this general umbrella of the ASPS was not very strong on aesthetics. But that's changed.
Yeah, it has. They've really put some effort to it. And like I said, I was pretty impressed. I saw some stuff that I was like, well, that may be something I might try. And then I saw a lot of stuff that I was like, yeah, no, not going to do that.
Pass.
Yeah, but, for instance, let's start with rhinoplasty. So rhinoplasty it's my probably biggest specialty, the largest part of my practice, although facelifts are closing in based on numbers. I have to say it's almost even now.
Hey.
So, but with rhinoplasty, we did a lot of chatting about, how to get people trained. And as I think everyone who listens to this podcast knows, we have a fellowship training program where we train fully trained plastic surgeons who have finished a residency and want to get excellent at doing the procedures, running a practice, et cetera. And then we also have the residents from USC that rotate with us as well. And we lecture internationally. As you said, you're going to Oslo to be the visiting professor for the Norwegian Society. Is that the one? It's Norwegian Society of Plastic Surgeons?
Mm-hmm. Yeah, it's Norwegian in combination with the American Aesthetic Society. But yeah.
Oh, that's great. So, we do a lot of teaching. And then we did a rhinoplasty course, which was well attended. There was about 110 people there.
Just a lot
Which is
for
a lot
rhinoplasty.
for rhinoplasty because it's kind of a niche specialty. Yeah. And the concepts were, how do you get people over that learning curve? How do you get them?
It's a long learning curve.
Right. You got to commit to it.
It'd be great if it was a nice steep learning curve, but it's not.
No.
It's kind of like a slow burn of a learning curve.
Yeah, it's like this, and then all of a sudden it takes off. And at some point,
At some point it takes off, but there's a slow burn in the beginning.
So that's where everybody was focused, was how to create systems of analysis and diagnosis to really get yourself to the next level in rhinoplasty. And I gave talks on the dorsal aesthetic lines, how you make the bridge look nice. And we talked about preservation rhinoplasty, where you don't disrupt the middle vault at all. You kind of cut all the way around the bones and push the whole bridge in, as a unit, versus taking it apart and putting it back together. So we did a lot of that. We talked about the tip of the nose and how to reconstruct it and how to do supporting grafts on the sides. So that was very effective. And then I gave a lecture on ethnic rhinoplasty, which, again, I hate that term because it's like, what
so all-encompassing,
yeah, like what rhinoplasty isn't an ethnic rhinoplasty?
Right.
I mean, even if you're taking care of, some, very normal looking Caucasian girl with a bump on her nose, like that's still like there's ethnicity there of some kind.
We
So,
all have an ethnicity to us.
yeah, so I don't know what ethnic
Yeah.
rhinoplasty is, but I talked a lot about, here's what I think about when the nose is flat and small and blah, blah, blah. And this is typically Asian rhinoplasty, but it can also be African American rhinoplasty. So we had that whole chat. And it was really good from a dialogue. The meeting left a lot of room for questions. And so I think, people were pretty satisfied with the rhinoplasty educational piece. And then I gave what I would tell my 20 years ago self to know to shorten the learning curve. Like if I had a time machine and I went back 20 years, what would I say to the Jay Calvert of 20 years ago? Which was when I really started getting heavily into rhinoplasty. And that was really good.
What would you say? What would you say to 20 years ago, Jay?
I said that the key is to take the cases that you really think you can make a difference and pass on the ones that aren't going to be better. Because even though you can probably help those patients in some little way or some way, shape, or form, you don't want to put them in a position to be dissatisfied and also for you to have to, come from behind and make things up. And I think, my patient selection now is very, very good because I know what I can do and what's not going to work. And when you're young, you want to help people.
You want to help them so badly, and they're coming to you and they're asking you for help, and you're like, I really want to help you. It's really hard. Like it's not that we're like money hungry, grabbing. We want to do all these cases. Like these people come to us with real problems, and you're like, I think I can help. I want to make it better. It's really hard. The saying no is really hard.
Yeah, so that was a very big lesson, and Mark Costantian and Rod Rorick, who were on the panel with me, both agreed. And I do want to say one thing because I was going to write Rod a letter, and I probably still will. But I think that Rod Rorick is probably one of the best rhinoplasty educators that's ever lived. I mean, he is so good. It was noticeable because I really worked on these talks myself, the ones I was giving. But every time that guy gets on the podium, I learn something. He's just a really talented educator. And he should be, not only commended for what he's done for plastic surgery, just with all the publications and the number of residents and fellows he's trained, but all the plastic surgeons with the Dallas Rhinoplasty Symposium that he does every year. And, and he didn't pay me to say any of this. I'm just saying it because I think, like if there's like a Lifetime Achievement Award coming up sometime, like this guy should get one.
How about that?
Yeah, it was really impressive to me because I'm sitting there trying to teach myself.
Right, and you're learning in the process.
And I'm trying to learn, like, how does this guy do this? Yeah. And, he's just really effective.
I think rhinoplasty is probably really hard to teach because there's so much nuance to it. You're talking about, millimeters of change in any direction to make a difference in the nose. And it's not even so much the technical aspect of it. We all graduate knowing how to do these things technically.
Right.
It's but when to do this procedure, or why would you do that, and what would make this better, or why not? It's the nuance of it and the decision making that I think are really hard to A, teach, and B, learn.
Yeah. Oh, for sure. And that's where I was kind of like there with there's Bob Gilman and Mark Costantian's just like a wealth of knowledge too. I mean, just we were talking about how do you identify the difficult, patient and what about
this was a good one. You had this talk, right? We talked about this.
Yeah. Oh, yeah.
What are your concerns about the difficult patient? Because we all have them. And if we're all honest out there as plastic surgeons, we know exactly what we mean when we say the difficult patient.
Yeah.
And we try and be PC about it to the general public because we don't want to come across as jerks. But there is sort of a general classification of warning signs that we see in consults that come in for a variety of reasons, nose, breast, whatever, that throw up these big red flags for us.
Well, and they're not red flags that there's a problem with the person. They're the red flags that they're not going to do well with plastic surgery. So when people who are patients are being told look, I don't think this is going to work for you, or, too many red flags or whatever anybody ever says to them, it's not that there's a problem with the patient. It's that plastic surgery isn't going to be a good thing for you based on our ability to serve you.
Right.
And that's where that combination of a patient who's not going to be happy with plastic surgery, who's getting plastic surgery now, it doesn't work.
It doesn't work. If you're treating a problem that you can't fix, that's a problem.
Right.
For you and for the patient.
Right. So that's what we had a lot of talks about that because, it is, there are so few patients now that actually make it into my exam room. I mean, it really is. We screen everybody out based on, where they live. Like there's some people that just are too far away to have a revision rhinoplasty with me, or, there's some things that just come up that you're like, that's not a good idea. This isn't going to work. Let me give you some different names. Let me send you there. But for the people that do make it into the exam room, like if they're there, then they're probably a really good. They're a good fit for what I do. And
but not every young plastic surgeon has that luxury.
No.
They'll take whoever calls and makes a consult, right?
Yep.
So for that young plastic surgeon, like they need to know, like, what are these warning signs?
And I said that. I go, when you're sitting there as a young plastic surgeon and you have these patients on your schedule to be seen for consults, and you walk in and your spidey senses go off and the hairs on the back of your neck stand up.
One.
And you're just like, ooh,
if you
this
just
doesn't feel right.
If all you want to do is get out of that exam room, that's like
don't
warning
operate.
sign number one.
I know that you have a big Allergan bill to pay for all your Botox and fillers, and you've got another, you got the rent to pay, but you know what? Extend the credit line, do something else, live to fight another day, because the problem is that won't work, and then you now have a problem that you have to take care of, which may cost you time, money, sleep, effort.
Just like the mental, the mental clarity
anguish,
and the stress that happens when you have a patient that you can go either one of two ways. You can do a great job and they can have a great result, but for whatever reason, they themselves don't see that because they have other issues going on, and that's a whole nother headache. Or you do a surgery and they're not happy because it didn't turn out the way you or them wanted it to, which is another huge problem. And it just adds up to a giant headache.
Yeah, and I talked a lot about sort of the way that you market yourself. And there's so much trickery and gaslighting in the marketing now. And I said the best way that you're going to build your practice is to know who you are and be yourself and be authentic. And if you present yourself the way that you are, where like the person that's on this podcast is the person that's in the exam room, is the person that's in the operating room, if all that lines up, it's going to make life very easy for you and for your patients to know who you are. And then you'll get the right patients. And that is a really key point. Like the stuff that I see, I mean, I don't want to get into it, but I see stuff that's just so egregious on the market. I don't know how, what kind of parents did these people have?
Who raised in a barn?
Who raised them to be so full of shit as a physician? How can you be so just massively deranged in your marketing of yourself? It's wacky, and it really. And I felt bad for our fellow Vic Mukherjee one day. I came in just on a rant,
You?
I did, and I know it's hard to believe, right? But I just came in and I was like, Vic, look at this, and he was like, yeah, that's really low. That's not fair to the public. That shouldn't and you think the public would know. You'd think they'd see some of this stuff and be like, oh my God, that is such BS. But they don't.
They don't.
They don't. They see it and they're like, oh my God, but it looks so pretty. It's so amazing. I was like, it's Photoshopped. It is Photoshopped. Yeah. And that's hard for people to understand. They don't get it. And they just go, yeah, but it's still really pretty. I want to go there.
Yeah. It's really hard, and I know we've done this whole marketing podcast before, and it's rough. But that was your rhinoplasty session.
But so the authenticity thing was really big.
And the red flags, and then you saw some breast ones as well.
All right, well, hang on a second.
Whoa.
All right, all right, everybody, hang on, because these are my friends, by the way, and I love them to death. Especially this breast panel were really. So I'm going to wail on them.
I know, oh gosh,
because they're really good guys.
Friends like that, okay.
Yeah, I mean, but really good people who are, I take their phone calls whenever they call about, somebody wants to do the fellowship or anything, and they're
love
amazing.
These guys.
They're amazing.
Yes,
they're amazing guys and women.
And gals.
Yeah, and gals. It was both. It was a mixed bag. But the push to try to not use breast implants right now is weird, because I mean everybody's in this BII, breast implant illness mindset, which I've always said, they're put in electively. You can take them out electively. If it cures your thyroid disease or your brain fog or whatever, great. And if it doesn't, then there's something else wrong. Go ahead and put them back in, because I've done that more times than I've left them out.
But let's talk about what these breasts look like without implants.
I just took some out for one of my patients. She's like, so they're going to look better than this. I was like,
No.
I hope so. I don't know.
know.
I mean,
I
we took
know.
out your implants. Like, they were really pretty and awesome.
know.
And now they're not.
I have a couple patients, right? You're giving me like PTSD. I have a couple patients right now that I'm dealing with this. We took out their implants because they were having issues for various reasons. And I just saw one of them like a few days ago, and I was like, so what do you think about putting them back in? Like, and she has her own reasons for why she doesn't want to, and I get that, and I respect that, and that's
Totally.
fine.
100%.
But you have to understand, like, what's left behind is sometimes irreparable without putting implants back in.
Yep.
And that's fine. If you don't want to don't put them back in. If you do not want to put them back in, but also don't expect that they're going to look anything close to how they used to be.
No, of course not. Even if you fat graft and all this other stuff.
No.
So some of the things that they were trying to do was put in like alloderm or stratus or something like that, some sort of acellular dermal matrix.
To do
And
what?
again, to augment the leftover breast, to try to get some volume.
So they were like folding it on itself?
Yeah,
and, like,
and putting it in a
But
pocket.
this stuff is absorbable, no?
It is absorbable, number one, but number two, it's also very firm. So like I was like, what's it going to feel like? Like you feel a Motiva implant, you're like, oh, I could sleep on this. It's really nice and soft. You feel a nice Allergan implant or whatever Mentor implants. They all have a different texture. Sientra, they all have different textures and feels to the gel, et cetera. And some are highly cohesive and some are this or that. Or
and they don't absorb.
But they don't absorb, number one. And number two, they're not hard. I don't like the idea of like putting in like a box of stuff. I mean, it accomplished the job. Like I looked at the results and the results were fine.
How far out?
Far out. They showed long-term results. And
So how is it lasting?
I think it gets replaced by tissue or scar or something. So it's put in under the breast, and the idea is that it volumizes it, and then as it gets replaced with whatever, it keeps the volume.
Okay.
And then they fat graft and everything. It's like it's this big effort.
By the way, this stuff is really expensive. Like this level of reconstruction is like twice as much as it would be to put in a pair of implants.
Of course.
And then you have to come back for a second surgery to fat graft and to scarvise and maybe put some more alloderm in. Then for a third surgery to put some more fat grafting in. Like it gets really expensive. That's kind of where I'm coming up against with some of these patients is like, how many more surgeries do I need to have to fix this?
Yeah. And so I was into that, and then I was like,
were
okay.
you into it?
I was in it.
I was watching
I'm not going to do it, I don't think. I mean, it's something, what though?
It's an
Let me tell you
option.
something.
It's
Right.
an option.
It's so good because maybe one day I'm going to see a patient and be like, it would be a good idea here. I've seen it done and I know how it can work, and let's try it.
No, for sure.
And I have used alloderm in gynecomastia repairs. So, just to take care of like a discoid deformity that's left over after somebody gets, really whacked. And I have used alloderm there when, there's some like ripped guy that has no fat anywhere. And fat grafting's not often, so you kind of like try to do the lipo to, do some equalization, and you put some alloderm in there. And, now there are some other options too. There's some allograft fat that's now out there in pretty big volumes. That's, we should, I should probably use it before I talk about it first, but that's available. Then there was also the concept of free flap augmentation.
No, that's a big one. So and that's kind of been percolating for a while. So which
makes sense.
Makes sense. We historically used free flaps. So a free flap, this is like plastic surgery 101, is when you reconstruct some defect in the body using tissue that is not adjacent to the area. So you're taking it from like the leg
abdomen.
or from the abdomen and putting it on the breast. And the only way that's going to survive is if you take it with its blood vessels, so the arteries and the veins, cut them off, move it as a unit to where you want to put it, the breast, and then connect those arteries and veins to the arteries deep in the chest. So you're not just moving things around and keeping it connected. You're literally taking it as a free unit, harvesting it, cutting it off, and then putting it in a brand new home and expecting it to survive by connecting these anastomoses, these fine arteries and vein anastomoses. And we do it all the time in reconstructive surgery. We do it all the time for breast reconstruction, typically after radiation, when implants aren't a great idea. But it's a labor-intense procedure. It's an expensive procedure, and it's not done routinely by a lot of plastic surgeons. So it's sort of been in this niche world of reconstructive surgeons.
Yeah, and it was Sean Boutros that was talking about that, who's a partner of Dr. Rednam.
Yeah,
who's on
we had our podcast.
Who was on our podcast. Maybe we should get Sean on. He would talk a lot about that. But first of all, it's called a free flap because you said it. It's taken free from the body and then reattached.
Moved,
so
yeah.
Yes, it's not that it's free because it is not free.
Not free.
It's so not free.
So not free. These are like, if your insurance covers it for reconstruction, great. But if you're paying for it out of pocket for cosmetic reasons,
It's going to be $150,000. It's got to be
expensive. But it's interesting because a lot of the surgeons I know who do this on a cosmetic basis are actually based out of Texas. Like there's like a thing in Texas for this kind of market.
You know, maybe they just went so hard line on the giant implants that now the pendulum has swung back the other way.
All those giant Dallas implants.
Yeah, everything's bigger in Texas. You know, like they went big. That's where breast augmentation was invented, was in Houston. So
I believe it.
You know, but that's there's a good movie actually about the invention of breast implant. Did you ever see that, Breast Men, with David Schwimmer and what's that guy's name? Chris Cooper. Not Chris Cooper. He's the director. It was a different actor named Cooper, but they did a movie about it. And David Schwimmer was like Cronin, and it was these two Houston-based plastic surgeons that invented breast augmentation.
Oh, wow.
Yeah, so it's a good film. But maybe that's why, because they've just went so hard on the big giant silicone implants, and now it's swung back, and they're trying not to have any implants, and let's use. But if you think about it, like, why not? You're taking the fat, and maybe some of the
surgery.
maybe a little cuff of muscle from the abdomen. Most people don't even take the muscle anymore; they just do these DIEP flaps,
and you get a tummy tuck as a result.
You get a tummy tuck, plus you get some breasts, and
makes sense.
Bob's your uncle.
Yeah, no, I think that's a great option for those people who have it and can afford it and can do it. It makes great sense.
Yeah, but it is pricey. But these guys, like the micro, when I did micro at the University of Pittsburgh, it was like a giant microscope and and now they have loops that are basically like that giant microscope, but you put them on, you could do it. You could probably do it in the office. I mean, I don't even know why.
Not in the office.
Not in the office, but in your office, like a surgery center. Yeah, I mean, I think you could really do it in like an office-based surgery center where, like ours, where it's Quad A, Medicare, and
but they have to be admitted somewhere. That's the thing for monitoring.
I think you have to have nurses watch them and monitor and all that.
Yeah, there's a way to do it.
I don't know. You have to go to the hospital for that.
You need a system for it. Number one, you need a system that's set up with the nurses and the monitoring. Typically, these are cases that are done in a hospital. They go to the ICU for a day or two
for monitoring.
For monitoring,
they're not sick or anything.
These flaps have to be checked every hour, and
they can't do that on the floor.
They can't do that on the floor, so you have to have an ICU nurse check them to make sure the blood supply is still there. So there's like what I tell my patients who might be candidates for this from a reconstructive standpoint is that it's a big investment up front. But if everything goes well, then you don't think about it for the rest of your life.
Right.
You don't have the problems that implants can present. You don't have the issues that can arise from having implants. You don't have to have them swapped out in 10, 20 years.
There's a corollary to this discussion.
Okay.
Is that they're using implants with the free flaps.
Okay.
So then you're getting the free flap and the implant and blah, blah, blah.
I thought these were for patients that didn't want implants.
It's all the above. But yeah, I mean, I thought it was really interesting, and it's like it is an option. And by the way, I don't think they really need to monitor anymore because I think the monitor is implantable.
It's true.
And then
it's on the surgeon's phone. Yeah.
Yeah. So I don't think they even need a nurse anymore.
Yeah, everything's definitely changing. But yeah, big investment, money, time-wise, it is an option. I do think it's a great option. But you definitely took something that seemed very simple when you were 22 years old and put in your implants, and now you're dealing with like potential ICU stays and 3-day hospitalizations.
And people get sick from having microsurgery. They can.
Yeah. They're big surgeries. These are big. These are like on the spectrum of surgeries that are done in the world. These are big surgeries. You have your brain surgeries and you have your bypasses. Like this is up there. Like maybe behind bypass. Like it's up there in terms of big deal surgeries.
I mean, the bypass is only a little more extensive because
it's the heart.
You're operating on, you're doing vascular changes on the heart and you're stopping it, but also you're cracking the chest. Yeah. This, you don't have that part of it, so it's not as
systemically.
But
it's not a systemic thing.
Yeah, you don't stop the heart, obviously, but I can tell you stories of.
And these are 8, 12-hour, 20. I've done 24-hour free flaps.
I mean, I can tell you 2 or 3 flaps that we lost because of like some coagulation problem and things that we just couldn't even explain. Like this, the operation goes great, and then we lose the flap.
Yeah,
you still got the tummy tuck, and now you can get your implants in, which sucks. But you spend a ton of money, a ton of time, and you don't have the results. So if you lose the flaps, it sucks. Yeah. And I'm sure that the percentage of flap loss in these elective cases is very,
It's
very,
real.
very low, though. But I
Yeah,
think
but it's real.
it's that same thing. It's like the chance of being killed by a Chihuahua is very low, but it's not zero.
Yeah. Yeah.
I have
All
a
right.
Chihuahua.
Well,
so
gosh,
I'm-
this conversation has been so cheery. So cheery.
Well, those are the things that I went to. I just wanted to learn, The facelift stuff was great. Let's go to the facelift stuff
right,
because
so
that
we're
was
going to
very
the facelift. Okay.
Yeah, so there were, great facelift panels and, all of them, we won't take a lot of time on them, but it's the usual suspects who spoke there. And they, the take-home message really was as long as you're doing something to the SMAS, you're going to get a great result.
Fine.
And the
Yeah.
tech has this is why people are so into facelifts now. It's should I get all this filler and everything, or should I just go get a facelift because the facelift works?
It works, by the way. It works.
It works in the most, basic of board certified plastic surgeons' hands. You're going to get a good result. It's going to be done well.
Yeah.
So that's why people are all in on the facelifts, and you don't have to do fancy stuff, SMASectomy, SMASplication, deep plane, and that they kind of dispelled the concept that the deep plane is this holy grail that some surgeons have made it out to be, who didn't invent it, by the way. I'm not going to get into that,
It's a whole different podcast.
Yeah, I know. It's enough already. That goes along with well, I invented this technique. It's you didn't. It's in a textbook from the 70s. No. Same with preservation rhinoplasty. Well, this is the way that, no, it was here's a paper from 1857 from Cottle that shows that he was doing this then. So, people like to dust off the old, paint it up, polish it, Kurt Vonnegut said that and call it, brandy new. It's not that way. But it was a good meeting from the standpoint of just getting to, be in the dialogue of what's going on in plastic surgery right now. And it changes every time I go to one of these meetings. It's different.
That's why we go.
Different constantly. Yeah. Advancing AI is taking medicine by storm. And it is radically altering the way that we practice medicine and will continue to. I promise you that. I mean, I don't know that the radiologists are going to do anything other than go yeah, that sounds about right, Frey.
Sign.
Yep, that looks good. Okay. Mm-hmm. Just because they need a doctor to sign off on it because the machine can't get sued. So somebody has to confirm. Yeah. But I mean, the AI is it is unbelievable. And we are at the very, very beginning of how it's going to advance things. So that was also very cool. Great. That's my take on it. That's my meeting.
I love it. Well, I love your meeting.
Food was amazing. Oysters were great.
By the way, this was in New Orleans. I don't think we said that.
So
which
good.
is an amazing city and one of my favorites for many reasons.
Love New Orleans.
I'm bummed I didn't get to go. But yeah, so New Orleans was great. Meeting was great. You learned and unlearned a lot of things.
Yes.
And we look forward to next year. Where is next year? Where is the meeting next year?
Je ne sais pas. I don't know. But I will be I think you and I will both be in Boston for the Aesthetic Society meeting. And I don't know whether or not you're going to take our good friend Dr. Schomburn up on his invitation for Fadna High's big deal thing in
Germany.
In Germany.
TBD.
Oh. In Berlin. That'll be really fun.
I do love my German plastic surgeons.
I know. It's really fun. But you are off to Oslo, so congratulations for getting that big invite. What did they have you do, 10 talks or something?
Dude, 6 plus moderating a few.
Hey,
they're getting the money's worth.
If they're flying you there, then they're going to make you work. That's the way that goes. Well, good. So that'll be awesome. We'll hear about it when you get back. Yes. But until then, this is the Beverly Hills Plastic Surgery Podcast, coming to you, first of all, with a public service message to watch on October 29th on TLC, Dr. Rovelo in About Face. And we are still here in the 90210.